Okay, good. Thank you. Thank you very much. Thank you, everybody. Hi. So I don't have video. It's my video. Yeah.
You can go ahead, Dr. Rahman. It's okay.
Yeah. Okay. So I will speak with you about my smile activities and in daily practice and ups to down. And for beginning, I will tell you about some words about smile. That's the first smile was performed by Zeiss 40 years before, and it's now considered to be the third generation laser treatment method after Perriquet and LASIK. And the main difference lies in the absence of a corneal flap, cutout, and corneal integrity is thus more respected. So this is how to do a smile. And one word about the corneal innervation that is superficial in the cornea. And when we do LASIK or Perriquet, we obligatory touch the corneal innervation. And smile, action of smile is deeper than innervation. When we do a good smile, we are deeper than corneal innervation. And also when we are opening the cornea, we have only less than 4 millimeters. And LASIK, we have more than 20 millimeters for opening. So smile is better for integrity of the anterior part of the cornea. And we can now take account the new selection criteria. So for Perriquet, all body were tooth okay, all okay. That's abstain for patient who will have a residual cornea less than 400 microns for Perriquet. And for LASIK in the same, 100 flap and 300 for corneal posterior wall. But with smile, we can leave only 250 with posterior wall. That's why we can leave the total cornea, residual cornea, 350. And that's why we can do more myops and until 10 dioptry and until 5 ciliand for astigmatism. So let's one word about surgery. Surgery must be more predictable. And the main idea is to how to identify the superior lenticle and the posterior lenticle. To identify the interface is very important for beginning and to be successful in smile. So these are the steps, and this is a smile of me. So this is my own method for surgery. I start beginning my smile for opening the anterior plane, and after that, I attack the posterior plane, and after that, I come back to the anterior plane and start dissection slowly through the cornea, and I progress carefully through over the lenticle, and I can go through the limits of the lenticle for the anterior plane. And after that, you can start with the posterior plane, and here you try to be only in the center to let the lenticle on place until the end. And after, in the end of the surgery, you can go through the lenticle, and with the forceps, a special forceps, not very thin, but a good one, you can remove the lenticle. This is the perfect smile for me. And if dissection of the posterior plane is performed first, we have more difficulty to find the anterior plane and dissect it, and it will increase trauma to the cornea and cause complications. Here, for example, an early discovery of the false plane. Here, I think that I am in anterior and then posterior, but during surgery, I realized that I was in false plane, and here as I start to dissect the anterior plane. So before I was in the posterior, and here you have always to begin with the anterior. It's more easier. And sometimes we have a late discovery of the fast posterior plane and the anterior plane. If we start surgery and we can stop and look for the anterior plane, like here, And after that, it will be more easy to do the same work every time. And if we have no possibility of catching the anterior plane by anterior way, we can catch it with the Sinski instruments, and we can catch the anterior plane by posterior way. And after that, we can remove here the lenticule with the forceps, capsulorhexis forceps, in one like this. Huh? Okay. So let's see some tips and tricks during surgery. Here is my bimanual technique. I can take my lenticule with the left hand, and with the right hand, I can remove the lenticule. Yeah. And this is the capsulorhexis-like technique. If the lenticule is still attached in one side, you don't have to
meeting is being recorded.
Yeah, you have to not to do this, but you can take the forceps and to go in the other side with the capsulorhexis, like capsulorhexis during cataract surgery, and it will be more easy to. And here, for my beginning and for the beginner, we can make the differentiator with the titanium instruments, and we can make once on the anterior and the second in the posterior, and in this way we can understand where is the anterior and the posterior plane. So something that we can have, management of loss of suction. It depends when we have its loss of suction. First step or second part of surgery. Here, there one case from one man, 30 years old, minus 350 and minus 250 myopes, and astigmatism 150, normal cornea, nothing. And here we have the femtosecond laser, who is acting with Visumax 500. And all thing is okay. First step, it's okay. The posterior plane is okay. So when he starts the section on the anterior plane by a femtosecond laser, in the end of the surgery, we have the conjunctiva who comes there. So no panic. We are surprised, of course, with this incident. So we got to check the nomogram and to check all the specificities, the diameter of cornea, and we can do flex. Flex is the same that it's like smile, but it's like circle. We do like LASIK. So the femtosecond here, and sorry, yes, the cutting is here. And so for surgery, we consider that we are like smile. Huh? Donc we do surgery. Of course, it's more easier to maintain the lenticule on place and to do surgery like a smile, to avoid to go through the incision. And after that, you can do surgery easily, like here, and remove the lenticule in the end of surgery. Here you are seeing, you can, through the lenticule, completely detached, and you go like LASIK. Here are the parameters, and the result post-op 10, 10, 10, 10, and 1 month post-op and 3 months post-op. Excellent results. So the main idea is to succeed with SMILE in invited to recognize both planes of the lenticule and to prevent intraoperative complications. We must adopt the same strategy to dissect the lenticule from the center to the periphery. The use of the same technique during SMILE surgery is a safe and effective method. This must be reproducible for all cases. So let's see some clinical cases. Here we have minus 27 years old, minus 6.25, and 10 to 10 after SMILE. And this one, pachymetry 527, and good keratometry. In this case, we have 25 years old, minus 9.50, and 2-cylinder astigmatism. And the other eye, 6.75, and 2-cylinder astigmatism. You see the result is 10 to 10 here, down. Excellent results. The patient is very happy. This is the keratometry preoperative, 521 and 13. This one, 31 years old, minus 3.75, mounting 4.75, little astigmatism, and 10 to 10 after surgery. And this is a thin cornea, 452, only 452. And after we have 383. And the patient is very good, very, very, very happy. And this one, 46 years. And here we do a Presby smile vision because we have dominant eye is the right, and the result is 10 to 10 with the 9 to 10 with this correction, and the patient is very happy. This is the cornea before, thin cornea and become thinner, but the patient is very happy with this Presby smile. So when we analyze, smile has a lot of advantages for precision refractive, for comfort, the patient, for dry syndrome, and biomechanic. Benefits as PRK and LASIK, wider optical zone, comfortable technique, no pain, fast recovery, no induced aberration, no burning smell, fast even in high myopia, using only one laser, no ACE, no hood issues, no interface syndrome, preserved by biomechanics and less dry eye. Limits requires perfect centering, requires an efficient manual dissection technique, less effective for irregular astigmatism, no topo guide treatments, not yet, no cyclotorsion except with Visumax 800 Smile Pro, no treatment for hyperopia except with Visumax 800, retouching by after PK LASIK, we can do circle or wrist smile, or PK, of course, the high cost of the procedure compared to PK or LASIK. How to optimize your smile? Achieve good refraction preoperatively, minimum.
دكتور عبد الرحمن إذا سمحت لي دكتور عبد الرحمن please if you don't mind 2 minutes more.
Okay, so I finish.
Please if you don't mind.
Achieve good refraction preoperatively, minimum energy allows faster visual recovery. Expert mode program is essential to clearly identify the anterior and the posterior plane. If decision to retouch, review the first surgery, helps choose the technique to use. In conclusion, for me, it's Relax Smile is the third generation refractive laser, and it's indicated in the first intention. We have to respect the contraindications. LASIK and PRK for certain specific cases, thin cornea with irregular or asymmetrical cornea, and do not treat the patients are at risk. Thank you very much for your attention, everybody.
Great, thanks, Dr. Abdul Rahman. I think that we will move to my presentation. So I will present the lenticular extraction, smart smile, and please, Abdul Rahman, just stop sharing if you don't mind,
Okay.
and I will share.
Is it okay?
Yeah. Yes. Now it's clear?
Yeah.
Okay. So I need to thank Dr. Muhammad to give us this opportunity, and hopefully that we can match the time. And I need to thank Abdurrahman that he makes my journey easier. And few things to comment that cyclotorsion is not present in Visumax Pro 800 till now. So let us see, it will be announced soon, but it present only, the only one is Atos Schwintamar. So I will start with the Smart Smile 2023 Atos. And I will start with this movie and will show you what's the effect and the importance of the points that Abdurrahman showed in Relax Smile 500 that present here now in this machine. This is MS39. The registration is a pre-register with a full registration. So start with MS39 registration and centration. And then all the information will be transferred to the machine. That information mainly is the registration. So here, the importance of the centration. The green cross is the eye and the yellow cross is the machine. When matched, we will start. with the torsional eye tract system active. And that's why when we are saying that we can correct astigmatism, it's correctable up to -5 with the lenticule started definitely posterior and then anterior, as Abdurrahman mentioned. And then removing the lenticule was showing a lot of changes with easier and nomogram that gives the best outcome and recovery that will be real within 24 hours, because mainly centration. So if we will go to what's present now as an advanced technology, here we have the Atos on the left, and we have Pro 800 from Visiomax, and we have the Z8, and also we have it's just sorry, the Elita, and Elita is not in the trade till now, but soon it will be in the trade. So if we will go to, as what mentioned by Dr. Abdurrahman, it's a painless surgery, high precision. The visual rehabilitation with the new, with our machine start to be almost equal to LASIK. So we can ensure the patient that he will have a good visual acuity post-op, and that's because of the centration, less coma, no need for a neural adaptation, less invasive than LASIK because there's no cut, better corneal biomechanic stability than LASIK, and that's shown by Dr. Abdurrahman, and we are running study shows depend on Corvus and comparing the PRK and the Smile, and shows that they have the same CBI post-op comparing to the LASIK, where it's the CBI is strongly effective. Less dry eye than LASIK, that's sure, and no flap-related complication, and there is wide optical zone. Now we are reaching up to 7.5, and the new software, it will reach to 8. Now I'm sorry that I need to move to see what's only one laser technique. And if we will go to the second, the centration, and as I said, that the centration and track system is one of the advanced that announced in Atos from Schwint, that can correct and can exactly correlate the visual axis to the center of the optical of the lenticule that will be removed. And that movie shows, it's a real movie, shows how I'm reaching and targeting the center. Here I start to start the vacuum, and you can see that the green cross is not matching the yellow cross because of the rotation. So the eye rotated, and this patient have a high astigmatism, -4.5, and it will be shown in the case that will be presented. So here we have two circles, the red circle and the yellow circle, and we need to target the yellow circle, where we will be within 200 micron from the center, from the visual axis. So the rate of the post-op induced coma will be very low, and that's what I will show you. And the other things is that the periphery of the lenticule is 0, so this will it will control the post-op spherical abrasion, and it will not increase the existing spherical abrasion. Instead, in my cases, it's reduced, and I'll show you in the higher order abrasions for the same case. And that's the case. It's a high astigmatism, -2 myopia with -4.5 on 170 with the rule, and it's been treated in a precise, and you can see here, with this high astigmatism, with this platform, we could reach to minus 0.250 astigmatism because of the centration and track system. And here, the high order abrasions, you can see the pre-op high order abrasions. And here I'm highlighting the comma from 0.35 to, I think that it's a 0.4. I need to get out of the site. Yes, the comma was for 0.35 to 0.4, and the spherical abrasion from minus 1.7 to minus 12. So it's reduced. So what's outlook in our side? The main issues is that hyperopic lenticule and the software for the suction loss. In spite of the presbyopic correction and hyperopic lenticule is the new software that will be announced once the Visiomax announce the hyperopic, because they have the right to announce it first. But what's the complication that Dr. Abdulrahman mentioned it in the suction loss? Sorry. Now, in suction loss, what we are doing, Abdulrahman shows that we can open the flap, or we can do a PRK, creating LASIK, opening the flap, or changing the nomogram. The nomogram change because when we don't have centration and track system, if we will duck again, we are not sure that we will return back to the same site, so we cannot do it immediately. That's why it needs time, and that time it was taking 3 months or 1 month at least, and changing the cup thickness to change the position of the lenticule, or changing the optical zone to change the thickness of the cup of the lenticule in a way that the surgeon will go to another dissection. But what's in our condition? We don't need that because the centration is the same. So I can go immediately to the same nomogram. Immediately means that I was in the first case waiting for 1 hour. Now I don't need to wait for 1 hour. Now there's a software. That software will go to the points where we stop, deduct few seconds, and it will return back to that point and continue. But till now, I'm using 1 hour difference between the suction loss. This is the case, and this is a real time where I did the posterior, and then I start with the anterior. Unfortunately, patient was hesitate, and you can see the bubbles on the right side. Anterior started, and then suction loss. Then immediately we took the high resolution suction of MS39. It shows that the suction goes only on the posterior, and there was no even visualization to the anterior suction. So 1 hour later, when the bubbles disappear, I start again on the same nomogram, the same centration, because I went to the center of the visual axis, and to the same centration I start, and I did it. And you can see this is a real time again, posterior, anterior, still the patient is moving. And then the side cut, here I used 3 millimeter. And then, as Abdulrahman mentioned, that we are starting with the anterior. I mark the anterior, then I mark the posterior here, separating it. But I prefer to go through the anterior first. As Abdulrahman said, I have a spatula that have a smooth surface, and the margin of it is a little bit widened. So from the periphery to the center, to the side periphery, and then posterior, here central, as Abdulrahman said, so in a way that I would not lose the flap, the lenticule, sorry. And then when I'm sure that the lenticule is start to be free, I have micro tying gauge 23 going through and remove the lenticule then showing it, and here I'm showing the full peripheral part of the lenticule in a way that it's removed in circle 360, and this is 1 hour after the surgery. And that the high resolution suction post-op immediately, and great thanks for all. Now, is anyone ready to give his, I think that Hasna is ready, Dr. Hasna? You are mute, Dr. Hasna?
I'm here.
Yes, my dear, Yallas, you can start. I will stop
Okay,
sharing,
you
sorry.
can stop sharing your,
Yeah, I will stop sharing. Just wait for me. It's unfortunately. Yeah, it stopped sharing, Mike. You can share. You can put your presentation and you can share. Is your presentation on the desktop?
Yes.
Okay, just press on share screen. The green button. The green button down. There is sharing screen.
Yes. I need
Okay, Dr. Hasna, we need to save the time, so we can go to Francisco if he's ready. Francisco, you are ready? Francisco, please unmute all the speakers, just to unmute, please. Francisco. He's not listening. So, Dr. Mahfouz? Dr. Hasna, you didn't find the sharing screen, my dear?
See, I find this, but I try to share my screen.
Yes, there is a button, green button down.
Oh, hello. Hi.
Yes, Francisco, if you are ready, just please share your presentation and
I
start.
can't hear you.
Okay, just wait. But I'm unmute. You cannot hear me?
I don't have the share screen. I don't have the share screen either. It's not here.
Why? Dr.
No,
Muhammad.
it's not showing.
Dr. Muhammad.
Okay.
I think.
You don't have in your Zoom share screen?
No, I'm listening to you, but the button for sharing is not here anymore. I think I need to be authorized.
طيب خلينا نخلص نشوف كيف حيكون.
Okay, and Dr. Mahfouz also, he's not here?
Okay, Doctor, can you have one of the management, please, to help Dr. Hasna or Dr. Francisco how to share screen? Okay, Doctor, are you able to see down? Can you go down? Click down. So you will see there participant chat, screen, share screen. Can you see that or not? It will be disappear. Just click any place, put your icon any place, click on the then you will see, yeah, any place in the screen, then you will see something down showing.
I can see the.
Yes.
Yeah, but the button is missing here.
No, it never can be missing. Maybe it's somewhere. Okay. Can you please do one thing? Can you go out and come back? Please just leave and come back. Yeah, disconnect. Okay, leave and and disconnect. Who is still there?
No one.
Francisco, can you hear me?
Yes.
Okay.
Okay, now.
Okay,
Now
Dr. Hasna is now it's good. Okay, Dr. Hasna, you can go ahead, please.
Yes, Dr. Hasna.
You see my
down.
Yeah.
You can click down. There is a TV-like button down. Just I can see it now.
Yeah,
down,
I can.
completely down. Dr. Hasna. Okay, you can start, Dr.
I
Hasna. Okay. Okay. Anyone from the management, please, you can take over. Okay, now, please.
Done, sir.
Okay. They will click for you, please. You can go and tell next, they will click for you.
Hi. دلوقتي معايا الكاميرا.
Can you please raise your voice? Can we hear you, Dr. Hasna, please?
Do you hear me?
Yeah,
Yes,
yeah,
we are hearing you. Please, you can start. Yes.
I guess, thank you very much. Sorry for this. I'm very happy to be with you. I have no financial disclosure for this presentation. Keratoconus is a bilateral, non-symmetric and non-inflammatory progressive corneal dystrophy. Cross-linking is a minimally invasive procedure used for the stabilization of corneal ectatic disorders such as keratoconus. In this speech, we want to share with you our primary results for a prospective study with simultaneous topo-guided PRK and accelerated corneal processing. Our study is about 8 patients, 14 EAs, aged between 25 to 35 years. We only choose keratoconus stage 1 for the beginning, and the diagnosis is based on pentacam and the OCT. The keratoconus must be stable, and the pachymetry is higher than 450. The treatment was topo-guided transepithelial
or as you said, I don't know, 20 or
and with maximal ablation.
Please, everyone can mute himself except Dr. Hasna, please. Everyone mute himself. Okay. Please,
our patient was treated by topo-guided transepithelial PRK based on pachymetry and subjective refraction. The maximal ablation was 60 microns. With the simultaneous, in the same time, we do accelerated corneal cross-linking, 10 minutes of riboflavin and 10 minutes of UV exposition. Our results was very nice because the uncorrected best visual acuity was was less than 510, and it's between 510 and 1010 after surgery. The corrected best visual acuity was best after after surgery, and the subjective refraction is less than before. The astigmatism is also less, and we have flattening of the cornea with the mean keratometry between 26 and 42. The pachymetry also is less after surgery. The means on postoperative pachymetry was between 340 and 400. And this is topography of patient before surgery, and after surgery we show flattening of the center of the cornea. And the second case also we have flattening of the center of the cornea after surgery. The follow-up of our patient is from 6 months to 2 years. No complication, also 2 cases of haze, and including one with impact on visual acuity, loss of 2 lines of visual acuity. In cases of keratoconus, photoablation was long time contraindicated, but there is many studies that show that is no progression after treatment by PRK. That is improvement of visual acuity without worsening of ectasia after PRK on non-progressive stage 1 and 2 keratoconus. And there is improvement of keratoconus and this is in 25 as is treated by PRK alone. PRK alone improves visual acuity, keratoconic indices, no worsening of ectasia. Is this a protective effect of PRK? Is this a protective effect of RK? The hypothesis is that PRK induced inflammation that stabilize the keratoconus. Topographed PRK is based on corneal topography, correct cylindrical refractive error with normalizing the corneal profile by smoothing the corneal surface. PRK can correct 70% of refraction with the maximum stromal ablation between 50 and 80, and with the minimal residual stromal dip of 340 to 400. Corneal cross-linking can be classic or accelerated, can be simultaneous or sequential. There is no difference between all protocols. Combined PRK with cross-linking is the only corneal refractive treatment authorized in the keratoconus. Several protocols are reported in the literature, but all the protocols have effective results. This is a meta-analysis of a French paper. There is 4 protocols of combined PRK and cross-linking with little differences between based on use of mitomycin, conventional or accelerated cross-linking, or the area of the treatment. We can combine PRK and cross-linking with other treatment when visual acuity is not satisfactory. The goal is to improve visual acuity as much as possible. We can associate it with the intracorneal ring. Classically, we begin by the intracorneal ring, and 6 months after we can do topographic PRK with corneal cross-linking if the patient didn't have before the cross-linking. We can also combine with phakic IOL to optimize the refractive result. We start with the intracorneal ring, followed by PRK and cross-linking. Then, when the visual acuity is insufficient, we can put phakic IOL to treat residual ametropia. The paper say that combined PRK and cross-linking is a safe and effective method to increase the visual acuity in the keratoconus. This treatment is for keratoconus stage 1 and 2, stable or evolutive. The objective and subjective refraction must be possible, and the patient have an insufficient visual acuity or intolerance to contact lens. Pachymetry must be greater than 450, and we can use this treatment even for the refractive surgery on suspicious cornea. This is the technique. This technique can be done when we have a stable keratoconus, or we have unstable keratoconus when the visual acuity is unacceptable. What about mitomycin? Very divided opinions. Some authors do not use it. Others use it routinely, saying that mitomycin will prevent the onset of haze and reduce its intensity. The mitomycin modulates the healing process by blocking activation and proliferation of keratocytes. In cases of combined PRK and cross-linking, there is no relationship of haze for pachymetry or the amount of ablected stroma. Some authors don't use it because the cross-linking in the anterior stroma reduce the number of keratocytes, and therefore they reduce the haze. Sequential or simultaneous treatment, there is no consensus. Someone say that it's more effective to combine the treatment in the same time, and others say that there is no difference between combined and sequential treatments. Different studies show that it is agreed that it is a safe and effective method. It's give best quality of vision and stabilize the keratoconus. The effective the maximum change is in the first year, then the parameters remain stable even after 10 years. The improved quality of life of the patient, and there is no specific complication reported by the authors. We can find classic complication of PRK, such pain, sterile subepithelial infiltrate, haze, epithelial healing delay, infection dry syndrome. This French meta-analysis for 9 studies show that is the most frequent complication is the haze, usually spontaneously regressive. In this study, there is no complication. In conclusion, this is a safe and effective method. It's the only corneal refractive treatment of the keratoconus. We can use it when we want to do refractive surgery for high-risk cornea. Can be combined with other surgery, but we don't know what is the long-term development because it's the turnover of the stroma is very slow. Before ending, I want to invite you to our congress in Marrakesh. It will be by 2 languages, French and English, and also for the Mayom and pressmen. Thank you so much, and sorry for the problems.
Thank you very much, Dr. Hasna, for this excellent presentation. You make it very fast. I know you are running fast to give us a space of time, but it's comprehensive and very nice presented. Maybe we'll keep some questions at the end of the presentation. If we can have Dr. Francisco, if you can share your screen now. Is it okay now? Is it able for you to share?
I think so.
Okay, please. Yeah, we can see yours, please.
Okay. So my name is Francisco Bandeira. I'm from Rio, Brazil. I'm going to end the session of refractive surgery talking a little bit about the topic that no one wants to talk about, post-LASIK ectasia. When the wind blows counter to what the ship wants. So I myself, I like a lot sailing. So I thought of this lecture to be more basic, with basic concepts. So what are the things that refractive surgery and sailing have in common? So for instance, to understand how boat flows, we need to understand the seawater, the depth, as much as we need to understand corneal anatomy, the layers, the cells that are within it, and the tissue interaction that the laser will have with it. Much like the oceans, we have a lot of refractive errors. So we can travel at different seas, which have different particularities, and we can have safe travels within a certain range of refractive errors. And we might get into some trouble if we try to venture ourselves in more tough refractive errors. Regarding the ships are much like the refractive laser suites. So the technology of the ships also evolved, and our technology for refractive surgery is continuously evolving as well. But the most difficult thing to understand about sailing is how the wind works. And for refractive surgery, I think that we do have a similarity with corneal biomechanics. This is the most difficult thing for us to understand. And that's where the complication of ectasia lies. So for a surgeon, we are the ship's captain, right? So we need to ensure patient safety. We need to understand the diagnostic exams as much as the captain needs to understand his boats, understand the ocean that he's traveling along with, and all of the items that will make a safe travel. And both of us need to have deep knowledge of our expertise. Sailors, they use specific tools to navigate and to make a safe travel and to reach their destinations, like compass, rulers, navigational charts. We as surgeons, we also use a lot of instruments. We need to understand the corneal thickness. We need to understand corneal curvature, and now more than ever, corneal epithelium and corneal biomechanics. But we also need to have a plan. It's not just understanding the exams, understanding the impact of surgery and what actual surgery will fit to each patient to customize the treatment that we are actually offering. So is post-LASIK ectasia important? That's a question that I like to ask. The incidence of ectasia for LASIK is very low. In this recent paper by Morsvar, he shows that it's less than 1%. For PRK, it's even less. And for SMILE, it has been shown similar ectasia profiles to PRK. So why is this important if there's so low incidence of this complication? The problem is what we're offering. What are the demands of our patient? patients want to be satisfied. So they want to get out of the surgery seeing it's a performance surgery. They don't want to see well for the first 3 weeks and then have a vision that will deteriorate. So we need to be responsible, and we need to ensure visual quality. And we also need to continuously research to improve our results and have a safer profile for these patients. So here's where I think the surgeon and the sailor, they do have to be very, very responsible, and they have to know what they're doing when the situation changes. How do we manage unpredictable situations? The sailor, if he faces a storm, he will need to know what to do. And if we face a corneal ectasia, we also need to know what to do. Ectasia, I think this has been talked over and over. It's a biomechanical corneal failure with several findings, ultrastructurally and biomechanically. Basically, it's a deformation that will result in poor vision. So how do we do to not have an ectasia? First, we need to understand the risks, the risk factors, and to stratify them and to see which procedure can we do for these patients. Second is, how do I diagnose ectasia? What are the findings that we have to look for? What do we need to pay attention to? And lastly, the treatment. If we are facing an ectasia, what can we do? How can we help these patients? So first thing is do no harm. We've learned this from med school with Hippocrates. And the first published papers come back to 1998 with Seiler. He had 3 cases above 10 diopters, and the residual bed was below 250. And then we understand a little bit more about the post-LASIK ectasia in patients that don't have a normal cornea, formed fruits keratoconus, for instance. And later on, Professor Ambrosio, my colleague, and Stephen Wilson, they suggested a residual bed limit. And further, more recently, Santiago also talked about the percentage of change in tissue. These things, they will affect and increase the risk of corneal ectasia. So what exactly are the risk factors for ectasia that we have identified so far? Corneal weakness is one of them. Inadequate corneal thickness, thin corneas, incorrect technical surgical technique, thick flaps, excessive ablations, and intrinsic factors. We know that younger patients, they tend to have more risk of ectasia, patients that have uncontrolled allergy and itching, family history of keratoconus, and pregnancy is also a risk for LASIK ectasia. Well, if we compare the surgery with saline, the misconceptions that we have about refractive surgery are the ones that can blow a ship off course. So we need to understand the surgical impact of all techniques to navigate the waters of refractive surgery smoothly. What do I mean by that? So it's the performance of LASIK is unbeatable. It's like a modern cruise ship. It gives the best results within the shortest period of time. But we cannot travel all waters with femtosecond LASIK. For PRK, it's an older boat. It's the first technique. It gives us better results, but it's not as comfortable as a modern cruise ship. With SMILE, we can travel into different kind of oceans. We can adventure ourselves a little bit more with a more comfortable situation. But we also have the phakic IOLs, which will be the submarine. With a submarine, you don't have to worry about tides. You don't have to worry about the wind. You are sheltered, but you can't always do phakic IOLs. For instance, in shallow waters, in shallow chambers, you cannot use phakic IOLs. So certification risk is crucial for us to decide which technique we are going to opt for our patients. And we do have several tools with artificial intelligence. I won't focus much on this because it's too specific, but I want to show you that these tools we can use to rule out which surgeries we can do and avoid ectasia. So this is what I want to show. These tools are freewares. They are available online, and you can actually stratify your risks quite simply with these platforms, and they will give you some idea of which kind of trouble you will get into if you decide to do a LASIK for some kind of patient or a PRK. We don't have this for SMILE yet. I don't think the developers and researchers are working on this yet, but it's quite simple, and it gives you an idea, and more than that, it gives you information that you can share with your patient, and you can put him on board about his risk situation. So this for me is it's quite important that the patient will understand that some surgeries will put him at risk. But once you perform the surgery, you also need to know what's happening. Where are you after surgery? How do you know if you're getting an ectasia or not? So this is my rationale for maintaining your ship on course. First thing, you need to emphasize the importance of adherence to follow-up schedule with your patients. I always tell them that they need to check the retina forever until they do their cataracts. So they will need to come at least once a year. Risk counseling and complications. If you decide to operate a patient that has a strange cornea or maybe a borderline situation, they need to understand that maybe they will need further interventions, and they might suffer some visual loss. You also need to have a program. You need to schedule these visits and monitor patient progress. If you see some changes, some different things in the exams, you don't need to keep up with the previous scheduling. You can shorten, you can reduce the space between consultations, and always try to get a corneal exam, tomography, topography, pachymetry maps, if you have the chance, because you don't know when these patients are coming back. And more importantly, if you see these changes—
1 minute, please, to conclude, if you don't mind.
I'm almost at the end. So, so when you are following these patients, the first thing that will show is the increase in myopia and astigmatism, and you also have changes in keratometric findings, in pachymetry and elevation maps, and more recently in biomechanics. So if you face a storm, the goal is to stay alive, right? We do have some options, but none of them are currently meet patient primary needs. We have corneal cross-linking, which we can associate with refractive surgery, PRK or PTK. We have contact lens, but they're not free of risks, and patients do want surgery to get rid of the lens. ICRS, accuracy is not so good. They require minimal thickness. There is risk of extrusion, and they do have some side effects. Corneal grafts, I don't even want to go down this way because it's the worst thing that can happen, and we don't want that for patients. More recently, we can add tissue, and there are some studies coming up that this might be a better solution for corneal ectasia. So my take-home lessons for post-LASIK ectasia are that refractive surgery is a high-performance surgery, and expectations are really high. Determining risks and disclosing them to patient is, to me, the most important thing when dealing with borderline cases, high myopias. And if we decide to go along with these high-risk profile patients, they need to be on board. They need to understand the situation. And we need to make sure that these patients don't get lost along the way. So we need to keep calling them. You need to have responsibility. I think this is what I had to say. Thank you for this invitation. And that's it.
Thank you very much, Dr. Francisco. This is very nice and excellent presentation, and your matching between the sailing and the refractive surgery ectasia. It's a great cooperation between them. So I think Dr. Al-Hadi is here, Mahfouz Al-Hadi. Okay, I think we have another 4 minutes. I know we are 15 minutes after our timing, but we will take 4 minutes, so they will start in 8, the next sessions. If there is any question from any one of you to another one, so for example, any question from Francisco or Hasna to Dr. Abdurrahman, he was talking about SMILE with Dr. Safwan. Dr. Hasna, she was covering the keratoconus, and Dr. Francisco, he was talking about post-LASIK. So any question from anyone to another one or not?
Yeah, the first one is, did you have any ectasia cases with SMILE?
No.
Okay, man.
Yeah, no. I am a SMILE user from 10 years now, but I never have the ectasia. No, because perhaps I do good indication. Perhaps I
Yeah, sure.
I got good seller. Yeah. No ectasia. No ectasia in my hand.
Dr. Hasna, you have any questions to Dr. Abdurrahman or to Dr. Francisco? Unmute yourself,
No.
please, Dr. Hasna. Okay, any question for about keratoconus to Dr. Hasna? Dr. Abdurrahman?
Yes, was very nice.
I think most of you are satisfied with the presentation for everyone. So I think we need, or to conclude our session, I would like to thank you all, Dr. Abdurrahman, Dr. Francisco, Dr. Hasna, for this excellent and comprehensive talks that you present in different diseases in cornea and refractive. And also thanks for Dr. Safwan. He left already because of some things that he wants to do. Thank you very much, and we'll see you, inshallah, in another session. Thank you, Doctor,
Thank you.
all of you.
Thank you.
Thank you.
Bye.
Thank you, Francisco.